next speaker, Andrew Browning from the US. As his topic is for more rigorous and formative. Andrew,
thank you very much. Is it coming through? So I feel in very good company because I think I probably also have too many slides and too little time. So I felt really good to see the last three talks that I'm in good company there. But I also am going to go a little off script to make the slide number issue even worse, which is that the previous three talks, I think, set mine up amazingly well, and we did not actually coordinate really beforehand. And what a kind of a common thread throughout a lot of the talks was about causation. And that's some of what we're talking about. And sometimes it was explicitly said, sometimes not. And so when this title in particular came from a paper that we put together a few years ago, and so it really is a brief summary of something that became an entire workshop. And so that's why I don't think 20 minutes will cover everything, but we'll touch on some. But one of the things, when you've got a phrase like toward more rigorous and informative nutrition epidemiology, one of the challenges is figuring out, well, if we're going towards something, we're probably going away from something else. We talked in some of the previous talks about rigor and informative and what those things mean. In particular, we're limiting to nutrition epidemiology and really wanting to focus on the causation. But specifically, I'm gonna focus a little bit on the manipulable causation. So things that we want to be able to go in and change. So there's a number of fantastic models that can come up with models of what may be causing something else. But ultimately, what we want to do is know how do we manipulate somebody's diet to result in a health improvement. So that's some of what is going to create the focus for some of my remarks. But I also wanted to emphasize, because one of the things when I talk about, trying to have more rigorous nutrition epidemiology is that sometimes I'm seen as a wet blanket or a crank or a downer. And what I'm just wanting to encourage is skepticism, not denialism. So really going through and being some of our strongest critics of our own work. So I have disclosures. I'll say that, the biggest one is that the views are my own. And so if you don't like what I have to say, blame me, not anybody else. But I've had the good fortune of working with a lot of different people, and I'll try to give credit as I go through. The slides will be available if you'd like them. One of the things I also do is if I put anything critical, I often try to anonymize it because I want it to be about the science and not the people. So we've got kind of two extremes often when we talk about nutrition epidemiology, and one is shown by Professor Ioannidis, who said nutrition epidemiology is a field that's grown old and died. At some point, we need to bury the corpse and move on to a more open, transparent, sharing, and controlled experimental way. That's one extreme. Another extreme, and this is a variation on a theme, but is that nutritional epidemiology has recently been criticized on several fronts. And although this one is from 2015, these types of commentaries show up frequently. But these criticisms, to a large degree, stem from a misunderstanding of the methodologic issues. Misunderstanding these issues can lead to the non-constructive and sometimes naive criticisms that we see today. So these are kind of two examples of extremes, which is nutrition epi is trash and everything with nutrition epi is fine. And of course, there's quite a middle ground. And that's what we tried to bring together a few years ago to talk about kind of that rational space between these two extremes. And you've heard some of those already this morning. And so, as I mentioned, this was, an entire workshop that we put together. So I obviously can't cover all of these things today, but the four domains were really considering stronger designs, stronger measurement, stronger analyses, and stronger execution and reporting. So what would a talk like this be without, bookends talking about a hierarchy of evidence? And I put a question mark there. And again, the prior talks have done a great job highlighting that it's not this simple. There are a lot of factors that go in to deciding where a study should go on a hierarchy of evidence, and not the least of which is that we need to have a causal question. Because a randomized controlled trial is not going to be a very good sample more often than not for your prediction. It's not usually gone out with the idea of representing a population. So first, we're talking about causal questions. Another is, are we even asking the same question about the same people? And so frequently what we have in RCTs versus nutritional epidemiological studies, and in RCT, we might have a really great understanding of the exposure because it was created and assigned. But more often than not, what do you get for an outcome? LDL cholesterol. But what you really want to know is about cardiovascular mortality. And so we extrapolate from that biomarker. Whereas on the nutrition epidemiological end, frequently we ask people what they eat and then run regressions, but then we actually get that outcome of interest. So they're different questions. Which one's higher? The randomized trial where we know we've controlled for a number of confounders just by design and have a good understanding of the exposure, or a long-term epidemiological study where we have a good assessment of the outcome? And the answer is it's not that simple, right? They're not on that same hierarchy in that case. There's also a question of when we talk about nutrition epidemiology, frequently what we're talking about is what some people have called ordinary association tests. And basically that's when confounding and other issues are predominantly controlled for by putting covariates in the model. And that's about as far as it goes. And those tend to have more issues with residual confounding than a number of other types of designs, some of which you've heard about today. And that fits between randomized trials and cohort studies. There's a lot more going on that people can do for designs, such as quasi or natural experiments, uncontrolled interventions. So we saw some of that in the first talk, where there was no control group, or it's not randomized, but you still have interventions. So there's a lot of different things we can do between these two extremes. And then for some of the questions we have, would an N of 1 study work? Is it good enough for you to be able to study yourself? I think allergies are the classic example of this, but certainly with glucose control, that happens as well. A randomized trial or observational studies might help you figure out where to start, but ultimately, you can try it on yourself and see how it goes, at least for some of the acute outcomes. So one of the examples that we used some years ago was breakfast and obesity. So this is a cumulative meta-analysis where we just happened to see all the studies where people were looking at breakfast eating versus breakfast skipping. And what you can see is that even in the first year that we pooled studies together, it was already statistically significant. And then it basically stayed flat over time. So people kept adding more and more studies to the point that the p-value at the end for this odds ratio was 10 to the negative 42. So I think at some point we probably could have stopped asking people, are you eating and skipping breakfast, and then looking at weight, right? Now the sad thing is hearing the example of a 20-year-old slide. This one is only 11 or 12 years old, but I still get asked to review papers where people ask, did you eat or skip breakfast, and then do correlations. So it's kind of these Me Too studies where the science is pretty well settled. We've seen the association. Can we ask that next new neat question? I think the next thing that's happening with that probably right now is ultra-processed foods, where everybody says, hey, I can try to figure out if my data set has ultra-processed foods in it, and they run a regression and see an associations. At some point, we can probably stop doing those and move on to some more probative questions. And just really briefly, we did meta-analyze the actual RCTs. There were very few, didn't see an effect in RCTs. And so this was in collaboration with my wife, Michelle Bohan-Brown, who I was lucky to have join me here. But again, the issue with the strength of the studies, right, is these are all small. It's hard to see, but, INS, the highest one is, 109. Weeks, anything from 1 to 16. So can we maybe roll back the next, dozen, 2 dozen, association studies and put those efforts into stronger randomized trials? I think that would be a good use of effort. So for each one of these 4, I'm just going to make some statements that people can argue with, but just a few thoughts at the end of the design analysis measurement. But the strength of design really depends on the intended use, but the ordinary association tests are usually a bit weaker for causal inference. Many designs exist between ordinary association tests and RCTs, so let's investigate some of those. But a common refrain is that RCTs are impossible, impractical, et cetera. But we've seen some even today with tens of thousands of people. So they're possible, and they just need to be worth it. So for stronger measurement, we've talked a little bit about self-report, which is, of course, the status quo. There were examples this morning already of other things that we can potentially do than just relying on self-report. But I take this quotation from authors who do value self-report, that recall is notoriously unreliable, as humans are notably bad at remembering detail. Now, I want to be fair. This was pulling, a quotation. Later, they do talk about the value of it still. So I'm not saying that they completely devalue it, but people that are really expert in this also understand the limitations. For energy intake and physical activity energy expenditure in particular, a group, including myself, some years ago now, wrote that, it's to the point where self-reported energy expenditure and energy intake is so bad that it doesn't actually inform our understanding of obesity in particular. So it's been shown time and time again against valid measurements to not give the right answer. And in fact, it misdirected the obesity field for a while, assuming that people with higher weights basically defied the laws of thermodynamics. So there's cases where we do need to move on. And one example that we did was there's this approach, Goldberg cutoffs, but there's other approaches where people will define what they feel is an implausible report and throw it out of the data set. The idea being, can we get to a set of individuals that we believe have more plausible reporting? And so this is using the eye data, the interactive diet and activity tracking in the American Association of Retired Persons. That's why I like saying eye data. It was about 300 individuals. They had biomarker data, apologies for the smaller font, but energy intake, sodium intake, potassium intake, protein intake. And as you would expect, there was systematic bias in the relationship between the biomarker and the self-report. But the thing that surprised me is, as you can see with these arrows, in each case, throwing out implausible reporters actually recovered an unbiased estimate of actual intake. I was floored. I didn't think it would work. But the big question that we really want to know is, do these methods retain associations? So understanding average intakes in a population is interesting, but what we want to know is, does that intake predict or explain an outcome? And so when we used the self-report versus the self-report after Goldberg rule versus our biomarker in the eye data informed simulations, we saw that in pretty much no case did the self-report, actually I take that back, heart rate, oddly, but otherwise using the Goldberg rules did not recover the associations between the nutrient and the outcome. And in fact, it didn't really have much of an improvement at all when looking at sodium, similar with potassium, similar with protein. So it sometimes improves self-report, sometimes improves self-report associations, but we still have bias in our estimates of the relationship between the nutrients and outcomes. So some of my thoughts on this, like I said, sometimes the adjustments can help recover unbiased average intakes, but that doesn't necessarily mean that we still get the relationship between the nutrient and the outcome. We talked in previous talks about the need for different, stronger, triangulating various methods of intake, so we can understand really what's going on better, and same with the new biomarkers and technologies for objective estimates of data collection as well. So I also thought there was going to be more discussion about Mendelian randomization. So I'm going to just say this briefly. But, here's a very simplistic causal graph for stronger analyses. And here, X of the exposure is thought to cause Y the outcome. And we have U confounders to correlate with X and Y. And what randomized trials are meant to do in part is break this leg. So we know what is causing the exposure, that it's not necessarily who somebody is or their habits, their culture. It's the trial that is causing the exposure. But there's also things like natural experiments that can hopefully break that leg as well. Mendelian randomization is a little bit different. So the idea here is that there is a genetic variant, and true experts in Mendelian randomization can correct me if I get these details slightly wrong. But here the genetic variant is what is being used as that intervention to cause a difference in the exposure. And the assumptions are that that single nucleotide polymorphism is going to affect the outcome Y only through exposure X, and that the SNP is not associated with confounders. So the idea here is that we're finding something kind of like a randomized trial where we're figuring out what is causing that difference, and it's beyond, an individual's preference and control. So this was the main point I was hoping to make with, a broader background in Mendelian randomization, is that we still have to have that critical thought. Because I have seen examples and been asked to, for instance, review papers where the SNPs are being used to predict and compare different types of milk consumption, high fat, low fat, no fat milk. But what is the mechanism that people can think of that a single nucleotide polymorphism will cause specific differences in the same type of milk? Now, dairy versus soy, maybe. That could make some sense, some of the lactose conversation. Similarly, people have used SNPs and air pollution. So can we figure out the causal effect of air pollution on obesity? And they've used these two-stage Mendelian randomization studies, but that doesn't necessarily make sense. What is the genetic factor that is going to cause somebody's exposure to air pollution? It doesn't make a whole lot of sense. So it still needs that scientific thought, even though these methods are so easy to use now. You can download a package, download the data, probably have one done by the end of the afternoon. So in the interest of time, this one is a lot of fun, but I'll move past that. But there was a conversation this morning about multiverse analyses. And so we did this approach with looking at beef consumption and heart disease. And there were all kinds of different ways that people were defining the covariates in these models. And so rather than looking at one or the other, we went ahead and calculated how many different models could be used under these different assumptions. It was about 4 quadrillion, I believe. And so we only simulated 1 million. So these are 1 million different models. Each one of these could, theoretically represent a paper on the association between beef and heart disease. And you can see the hazard ratios vary substantially. Only the ones down here at the extremes show a statistically significant association. So the question is, which one's right, if any of them? And so when choosing amongst 4 quadrillion models, that's something that the field is really working on right now. And one quick thing, people will say, well, we've got AI and machine learning, so that'll take care of a number of things. Still doesn't save us quite yet, because what we've put into the data and put into our sampling is the same limitations that will be propagated onto any sort of AI or machine learning approach that we use. So I think I'm down to about 1 minute. So I will just talk about the reporting in particular. So those other slides, happy to discuss more, are related to how we evaluate nutrition science and grading and things like that. And some different groups have come up with alternative approaches to decide what is and isn't a high quality evidence in nutrition, as though causation acts differently in nutrition. But one thing that is important is reporting. So the strobe nut guidelines are things that should be increasingly used to get at some of the additional details that can help us in understanding associations with nutrition. We do headline versus study every day for communicating research more broadly. So we have the obesity and energetics offerings that you're welcome to subscribe to, but we show a headline and then say what the study actually showed. And again, I'm happy to share these slides, but frequently they don't match, as you could imagine. So communicating to the public is also very important. So going forward, so what I'm trying to do is not end as a wet blanket, not end as a downer. And it's the idea of, in building off of the previous 3 talks, is what can we do better with each one of our studies? So let's say the one that, we're going to present on today is, an ordinary association test. That's okay. But what do we do next? I think Simon made that point very clearly about, well, start here and then build, keep building on it, and each time do a little bit better of a study. And I'll just end with the quotation about epistemologically, there's no reason nutritional sciences should settle for lower standards. So that's what I'm trying to encourage, is keep pushing these standards up, not for denialism, but healthy skepticism.
Thank you, Andy.